All right, so we're going to do a deep dive on abdominal wall anatomy and ventral hernia repair.
Okay.
And this is really going to be kind of a focused review and, thinking about the key concepts you need for your surgical boards.
Absolutely.
So, hopefully avoiding kind of getting lost in the weeds too much and really giving you those essential nuggets.
Yeah, actionable information.
Actionable information, exactly.
Yeah. Because sometimes you can get bogged down, with the minutia,
Totally.
and you really just need kind of the core concepts to succeed.
Yeah, for sure. For sure.
So let's jump right in. We'll start with the anatomy, right? The abdominal wall.
Yeah.
It's this layered structure. So kind of think of it as 6 components, starting from the skin, working our way down.
Okay.
So we have skin and subcutaneous fat,
Right?
the superficial fascia, which is made up of Camper's and Scarpa's fascia.
Okay.
Then we have the myofascial layer, which we'll dive into a bit deeper,
Right.
the transversalis fascia, then the intraperitoneal fat, and finally the parietal peritoneum.
So a lot of layers there.
It is a lot of layers, yeah.
And what are the main roles of the abdominal wall?
I think of it as 2 main things. Coverage. It's literally covering all of our abdominal contents.
Right.
But then there's also this really important myofascial support that it provides.
Yeah. It kind of keeps everything in place.
Absolutely. It's like our internal weightlifting belt.
So where do we even start with the boundaries of this whole area?
So we'll focus on the anterior and anterolateral abdominal wall for this discussion.
Okay.
So superiorly, it's bounded by the xiphoid process
Right.
and the costal cartilages of ribs, 7 through 12.
Mm-hmm.
Then inferiorly, we have the pubic tubercle and the inguinal ligament.
Okay.
And then if you go laterally, that's the mid-axillary line that forms the boundary.
Okay. That makes sense. So now we're talking muscles, right?
Yeah, muscles. So we have 5 paired muscles in this region that are really crucial for us to know.
Okay. I'm ready.
So first up is the rectus abdominis.
Okay. The six-pack muscle.
It's
Yeah.
exactly. That's the one everybody thinks of. So it originates from the pubic symphysis and pubic crest,
Right.
and then inserts on the xiphoid process and the costal cartilages of ribs 5 through 7.
Got it. And I remember something about tendinous inscriptions.
Oh, yes. The tendinous inscription is very important. These are kind of like these horizontal bands of fibrous tissue within the rectus abdominis.
Okay.
And they're located at the level of the umbilicus, the
Correct.
xiphoid process, and then there's one kind of halfway between those two.
I see.
And they actually really contribute to how the rectus functions.
Oh, really? How so?
Well, they divide the muscle into segments, and each segment can actually be innervated separately.
Huh. Interesting.
Yeah, so you can have different parts of the rectus contracting independently, which is pretty cool.
That is pretty cool.
All right, so moving on to the next muscle, we have the external oblique.
Okay.
And this one originates from the external surfaces of the lower 8 ribs, so ribs 5 through 12.
Okay.
And it inserts onto the linea alba, which we'll talk about more in a bit. But it does so through this broad aponeurosis, which is basically a sheet-like tendon.
Right. I remember that from anatomy.
And the fibers of the external oblique run in a downward and inward direction, kind of like if you put your hands in your pocket.
Oh, yeah. Okay. I can visualize that.
Good. So then we have the internal oblique, which sits right underneath the external oblique.
Okay.
And its origin's a bit more complex. It comes from the thoracolumbar fascia, the iliac crest, and the inguinal ligament.
All right. A lot going on there.
Yeah. And it inserts on the lower ribs and the linea alba, similar to the external oblique.
Uh-huh. But I'm guessing the fiber direction is different.
They run upwards and inwards, so almost perpendicular to the external oblique fibers.
So they kind of crisscross.
Exactly. And that's really important for rotational stability and core strength.
That makes sense. So what's next?
Next, we have the transversus abdominis. So as the name suggests, its fibers run transversely.
Across the abdomen.
Yes,
Yeah.
across the abdomen. And it has a broad origin from the lower 6 ribs, the thoracolumbar fascia, the iliac crest, and the inguinal ligament.
Okay. I see a pattern here with those last few.
Right. They all kind of come from similar areas.
Yeah.
And the transversus inserts on the linea alba as well.
Got it. So like a corset.
Exactly like a corset, providing that deep support for the abdominal contents.
All right. And the last one.
The last one is the pyramidalis muscle. It's a tiny little muscle that lies in front of the rectus abdominis.
I vaguely remember this one.
Yeah, it's not always present, and it doesn't really have a major function, but it's good to know it exists.
Okay, so those are our 5 paired muscles.
5 paired muscles, got it.
What about all the fascia in the abdominal wall?
Ah, yes, the fascia. So there's a few key structures here.
Okay, hit me with them.
First, we have the linea alba.
Right down the middle.
Right down the midline. It's this tough, fibrous band that runs from the xiphoid process all the way down to the pubic symphysis.
And it's formed by what?
It's formed by the fusion of the aponeuroses of all the abdominal muscles.
Oh, so they all kind of meet there.
Exactly. They all kind of come together at the linea alba.
Okay, what else?
Then we have the linea semilunaris, which marks the lateral border of the rectus abdominis muscle.
Okay, so it's kind of like the dividing line.
Yeah, you can think of it that way. It separates the rectus from the other abdominal muscles.
Got it.
And then finally, we have the rectus sheath. This is a really important one, especially from a surgical standpoint.
Okay, why is that?
Well, it's basically a fibrous compartment that encloses the rectus abdominis muscle.
I see.
And the composition of this sheath changes depending on whether you're above or below a structure called the arcuate line.
Okay, this is where it gets a little tricky.
It can be a bit tricky. So above the arcuate line, the anterior rectus sheath is formed by the aponeuroses of the external oblique and the anterior layer of the internal oblique.
So 2 layers there.
2 layers there, and then the posterior rectus sheath above the arcuate line is made up of the posterior layer of the internal oblique and the transversus abdominis aponeurosis, and it's all reinforced by the transverse thysis fascia.
So also 2 layers posteriorly.
Yes, but below the arcuate line, things change a bit. Well, the anterior sheath still has the external oblique aponeurosis,
Okay.
but now it also includes both layers of the internal oblique aponeurosis and the transversus abdominis aponeurosis.
So all 3 of them.
All 3 of them contribute to the anterior sheath below the arcuate line.
Okay, and what about the posterior sheath?
The posterior sheath below the arcuate line is just the transversalis fascia.
Ah, so it's much thinner down there.
Much thinner, and this is really important because it creates a weak spot in the abdominal wall.
Right, I can see how that could be a problem.
Yeah, this area below the arcuate line is a common site for hernias.
Okay, so the arcuate line is like a key landmark then.
Absolutely. It's crucial for understanding the anatomy of the rectus sheath and for planning surgical approaches.
So where exactly is it located?
It's roughly at the level of the anterior superior iliac spine, so kind of in the lower abdomen.
Okay, I'll make a note of that.
Good. So let's switch gears a bit and talk about the blood supply to the abdominal wall.
All right, we got to keep the tissues alive.
Exactly. So the good news is the abdominal wall has a very robust blood supply.
I'm hearing that's good news.
It is, each muscle has its own set of named vessels that supply it.
Okay.
But what's really important from a surgical perspective is the blood supply to the skin and subcutaneous tissues.
Right, thinking about flaps and things like that.
Exactly. So luckily, the skin and subcutaneous tissues have really great collateralization.
Meaning lots of interconnections.
Exactly, meaning we can raise these random pattern flaps without having to worry too much about strict anatomical boundaries.
That's awesome. So how do we think about this blood supply then?
A helpful way to conceptualize it is through these zones that are based on the dominant blood vessels.
Okay, what are these zones called?
These are called the Huger zones,
Huger zones.
and there are 3 of them.
I'm ready.
Zone 1 is the periumbilical region. So think from the xiphoid all the way down to the pubic symphysis.
Okay.
And laterally, it extends to the lateral borders of the rectus muscles.
All right, so right down the middle, basically.
Right down the middle. And this zone is supplied mainly by the superior and deep inferior epigastric arteries.
So 2 main players.
2 main players, and they form an anastomosis near the umbilicus.
Okay.
Now, the deep inferior epigastric artery is usually the dominant vessel.
Dominant meaning what?
Dominant meaning it contributes the most blood flow to this region.
Got it.
And it has these medial and lateral rows of perforators that pierce the rectus abdominis.
Okay.
And here's a key point. Most of these perforators are actually clustered within a few centimeters of the umbilicus.
So that's a pretty important area.
Huge importance, yeah,
Yeah.
especially the medial row. Those perforators can even supply the skin on the other side of the midline.
Wow, so they cross over.
Yeah, pretty amazing. So if you're ever planning incisions or flaps in this area, you have to keep that in mind.
Right. You don't want to compromise that blood supply.
Exactly.
Okay, so that's zone 1. What about zone 2?
Zone 2 is kind of like the lower abdomen overlapping a bit with the lower part of zone 1.
Okay, so where are the boundaries?
So picture a line drawn from the anterior superior iliac spine up to the pubic symphysis
Right.
and then down to the groin crease.
Okay, so kind of a triangle shape.
Yes, a triangle shape. And this zone is supplied by a few different vessels.
Like what?
So you have the deep inferior epigastric artery perforators again,
Okay.
but also the superficial circumflex iliac artery, the superficial inferior epigastric artery, and the external pudendal artery.
And these run how?
They run from lateral to medial.
Okay. I'm picturing them like a row.
Yeah, exactly like a row. So if you're doing a lower abdominal flap, you need to know about these vessels.
All right, zone 2 down. What about zone 3?
Zone 3 is located above zone 2 and laterally to the rectus abdominis muscle.
Okay, kind of like the flank area.
Yeah, the flank area and its blood supply comes primarily from the thoracic intercostal perforators from T7 to T12,
Okay.
and also the first lumbar neurovascular pedicle.
So this one's coming from above and below.
Exactly. It's kind of like a backup
What,
system.
what do you mean?
Well, if the main blood supply to zones 1 and 2 is compromised for some reason,
Uh-huh.
zone 3 can still provide perfusion to the abdominal wall.
So it's like a safety net.
Exactly. A safety net. Very important.
All right, so we've got the blood supply down. What about the nerves in this region?
So innervation to the abdominal wall comes mainly from the ventral rami of spinal nerves, T7 to L1.
Okay.
And these nerves provide both motor and sensory function.
So they control the muscles and give us sensation.
That's right. Now the anterolateral abdominal wall receives its innervation from the thoracic perforators.
Okay.
And these perforators run in the plane just below the internal oblique muscle.
All right. And what about the rectus abdominis?
The rectus is innervated by perforators that pierce the posterior rectus sheath and travel more immediately.
Got it. And are there any other nerves we need to know about specifically?
Yes, there are two very important nerves called the iliohypogastric and ilioinguinal nerves.
Okay, I've heard of those before. Why are they important?
Well, they provide sensory innervation to the hypogastric region and the upper medial thigh, respectively.
Okay.
And they run in a very specific location between the internal oblique and transversus abdominis muscles.
Right.
So they're particularly vulnerable during procedures like component separation where we're working in that plane.
I see. So you have to be extra careful not to damage those nerves.
Absolutely. You don't want to cause chronic pain or numbness for your patient.
Okay, so now that we've covered the basic anatomy, let's dive into ventral hernia repair.
Okay.
So what is the root cause of a hernia forming in the first place?
Well, at its core, it's a loss of integrity in the structural layers of the abdominal wall.
Okay, so a weakness in the wall.
Yes, a weakness or a defect. And when that happens, the abdominal wall can't withstand normal intra-abdominal pressure.
Right, so things start to push through.
Exactly. That's how you get a hernia.
So when we're thinking about VHR for boards, what are the big things we need to focus on?
I would say there are two main areas. First, understanding the risk factors for surgical site occurrences and infections.
So SSOs and infections.
Yeah. And then second, understanding the risk factors for hernia recurrence.
Because nobody wants their hernia to come back.
Nobody wants that, no.
So let's start with SSOs and infections. What are the risk factors there?
It's actually multifactorial. There are patient-specific things, wound characteristics, and even the choice of repair material can play a role.
So lots of factors at play.
Exactly. It's not just one thing.
Okay, so what are some of the patient-specific things that increase the risk of infection?
Well, some of the big ones are smoking diabetes, COPD, coronary artery disease.
Okay, so a lot of those chronic medical conditions.
Yes,
Yeah.
exactly.
What else?
Nutritional status is really important. So if someone has low albumin preoperatively, that's a big red flag.
Okay, makes sense.
Also, obesity, advanced age, any kind of immunosuppression, whether it's from medications or disease,
Right.
and chronic steroid use.
So these are all things that kind of weaken the body's defenses.
Exactly.
Yeah.
They impair wound healing and make it harder to fight off infection.
Okay, and you said wound characteristics matter too. How so?
Things like the size and location of the wound, the level of contamination, all of that plays a role.
Right, so a big dirty wound is obviously higher risk.
Exactly.
Okay, and what about the repair material? You mentioned that as a factor.
Yeah, so certain materials are more prone to infection than others.
Like what?
Well, we'll talk more about the specifics later, but generally, synthetic mesh has a higher risk of infection compared to biologic mesh.
Okay, that's good to know. So basically, we need to think about the patient, the wound, and the materials we're using.
Absolutely. It's all connected.
All right, so now let's talk about hernia recurrence. What causes that?
Well, as you might imagine, surgical technique is a huge factor.
Right, if the repair isn't done well, it's more likely to fail.
Exactly. There are certain principles we need to follow to ensure a strong and durable repair.
Okay, we'll get into those later.
But patient factors also play a role. Well, anything that increases intra-abdominal pressure can put stress on the repair and make it more likely to recur.
So things like obesity or chronic coughing.
Exactly. And certain medical conditions can weaken the tissues and make them more prone to tearing.
Okay, and what about wound factors?
This is a big one. Infection is a major contributor to hernia recurrence.
So even if the surgery is perfect, if the wound gets infected, the repair could fail.
That's right. It can really disrupt the healing process and weaken the tissues.
Okay, that makes sense. So it's not just about the surgery itself, it's about everything that happens afterwards too.
Absolutely. Wound care is just as important as the surgical technique.
Okay, so you mentioned surgical technique being important. Let's talk about some of those key principles for preventing wound dehiscence.
Yeah, so dehiscence is basically when the wound edge is separate.
And that's bad.
That's very bad.
Bad.
So to prevent that, we need to make sure we're taking wide bites of tissue with our sutures.
Okay, so getting a good grip.
Yes, a good grip. And we want to use short intervals between our stitches so that the tension is evenly distributed.
So not too far apart.
Exactly. And we also want to make sure we're not putting too much tension on the suture line.
Right, it needs to be secure but not strangulating the tissues.
Exactly. You don't want to cut off the blood supply.
Okay. And is there an optimal stitch placement?
Generally, we aim for about 1 centimeter from the fascial edge
Okay.
and about 1 centimeter between each stitch.
So nice and even.
Yes, nice. And even that helps to distribute the tension and minimize the risk of dehiscence.
All right, so that's surgical technique. What about patient evaluation? What do we need to do before we even get to the operating room?
Well, a thorough history is absolutely essential.
Okay, what are we looking for in the history?
Well, we need to know about all their comorbidities, so any medical problems they have.
Like the things we talked about earlier.
Exactly. Those are all important.
Yeah.
We also need to know about their surgical history.
So have they had any previous abdominal surgeries?
Yes, particularly any previous hernia repairs.
Right, because that could affect things.
Absolutely. And we need to know about their current medications. Some medications can interfere with wound healing.
Oh, right, like steroids.
Exactly. And we need to get a good social history. So things like smoking status, alcohol use, drug use.
Okay. And why is that important?
Because all of those things can affect their overall health and their ability to heal.
Right, they can increase the risk of complications.
Exactly. And we also need to ask about any history of radiation to the abdominal wall.
Radiation, why is that relevant?
Because radiation can damage the tissues and make them more difficult to work with.
Oh, okay, so it's like another factor that can weaken the abdominal wall.
Yes, exactly.
Okay, so that's the history. What about the physical exam?
The physical exam is crucial. We need to determine if the hernia is acute or chronic.
What's the difference?
An acute hernia is one that's happened recently,
Okay,
while a chronic hernia is one that's been there for a while.
all right, and why does that matter?
It can affect the surgical approach.
I see.
We also need to identify the specific tissues involved in the hernia.
So is it just fat protruding, or are there other organs involved?
Exactly. We need to know what's in the hernia sac.
Okay.
We also need to carefully measure the size of the defect.
And how do you do that?
Well, we examine the patient both supine and standing if they can tolerate it.
Okay. So in different positions.
Yes, because the size and shape of their hernia can change depending on their position.
That makes sense.
We also need to look for any signs of wound contamination.
So is the skin red or swollen?
Exactly. We need to assess the cleanliness of the area.
Okay.
And it's important to note if there's an ostomy in the vicinity.
An ostomy. What's that?
An ostomy is basically a surgical opening in the abdomen that allows stool or urine to pass.
Okay.
And if there's an ostomy near the hernia, it can complicate the repair.
Right, because you don't want to contaminate the surgical field.
Exactly.
Okay, and you said something about fistulas.
Yes, we need to check for any interocutaneous fistulas.
What are those?
A fistula is an abnormal connection between the intestine and the skin.
Oh, wow, that sounds serious.
It can be very serious, and it makes the repair much more challenging.
Okay, so those are all things we need to assess on physical exam.
Yes, it's a very thorough exam.
All right, and what about preoperative workup? What tests do we need to order?
So typically we get some blood tests.
Okay, like what?
We check their electrolytes and their albumin level.
And why is albumin important?
Albumin is a protein that's a marker of nutritional status.
Okay.
And if it's low, it can indicate that the patient is malnourished.
Which could affect their healing.
Exactly.
Okay, and what about imaging? Do we need any scans?
Yes, a CT scan of the abdomen and pelvis is usually necessary.
And what does that show us?
It helps us to visualize the size and location of the hernia defect.
Okay.
And it also lets us assess the surrounding abdominal wall muscles.
So we can plan our approach.
Exactly.
And what about fistulas? You mentioned those earlier.
If a fistula is present, we might also get a fistulogram.
And what is that?
It's a special X-ray that uses contrast dye to map out the track of the fistula.
Okay, so we can see exactly where it goes.
Exactly.
All right, so that's our preoperative workup. And then we need to think about hernia grading systems, right?
Ah, yes. The grading systems, they're important for communicating risk and understanding the literature.
So what are the main systems we need to know?
Well, the most widely used system is the Ventral Hernia Working Group Classification, or VHWG.
Okay, what's that all about?
It's a 4-tiered system that predicts the risk of surgical site complications.
Okay.
and it's based on the level of contamination and the presence of comorbidities.
So it's kind of a risk stratification tool.
Exactly. It helps us to categorize patients and make informed decisions about their management.
Okay, so what are the 4 grades?
Grade 1 is considered low risk. These are typically clean cases with minimal comorbidities.
Okay.
Grade 2 involves patients with significant comorbidities like the ones we talked about earlier.
Right.
Grade 3 includes cases where we anticipate contamination.
So like a contaminated wound or a bowel resection?
Exactly. And grade 4 signifies active infection.
So that's the highest risk category?
Yes, those cases are the most challenging and often require specialized techniques.
Okay, so that's the VHWG. Are there any other systems?
There are a couple of others that you should be aware of.
Okay.
There's the validated 3-tiered model proposed by Rosen
All right.
and the modified 3-grade system by Cantors.
So these are just different ways of classifying hernias?
Yes, they all have their own nuances.
Yeah.
But the VHWG is the most common one you'll encounter.
Okay, good to know.
So now let's shift gears and talk about the actual reconstruction of abdominal wall defects.
Okay, the main event.
Exactly. So before we even get to the operating room, we need to think about optimizing the patient,
Okay. The meaning what?
meaning getting them as healthy as possible before surgery.
Makes sense.
So if they're malnourished, we need to address that through nutritional support.
Right, getting their protein levels up.
Exactly. We need to make sure their blood sugar is well controlled.
Especially if they're diabetic.
Yes, and if they're smokers, we encourage them to quit.
Smoking cessation is always a good idea.
Always. And we might also need to optimize their oxygenation if they have underlying lung problems. And for obese patients, we often recommend weight loss.
So basically doing everything we can to minimize their risk of complications.
Exactly. The healthier they are going into surgery, the better their chances of a successful outcome.
Right, so that's patient optimization. What about preparing the wound itself?
Well, we need to thoroughly clean the wound and remove any debris or infected tissue.
So reducing the bacterial burden?
Exactly.
Yeah.
We want to create as clean a surgical field as possible.
Makes sense. And sometimes there are adhesions, right?
Ah, yes, adhesions. These are bands of scar tissue that can form between organs or between organs in the abdominal wall.
Okay.
And we need to carefully lyse those adhesions to restore normal anatomy.
So it's like freeing things up.
Exactly, freeing things up so that we can work more effectively.
Okay, so once we have a clean surgical field, what's the next step?
Well, a central concept in abdominal wall reconstruction is reapproximation and centralization of the rectus abdominis muscles.
So bringing those muscles back together.
Exactly. We want to restore the normal anatomy as much as possible.
And how do we do that?
Often this involves using component-separated techniques.
Okay, we talked about that a little bit before. Can you remind me what that is?
Sure. Component separation is basically a way to create more mobility in the abdominal wall.
Okay.
It involves making incisions in the fascia to release the rectus muscles from their attachments.
I see. So we're basically giving ourselves more room to work with.
Exactly. We
Yeah.
can then pull those muscles back together without putting too much tension on the repair.
That makes sense. And then we usually use some kind of reinforcement, right?
Right. Usually we need to reinforce the repair with mesh or other materials.
Okay, we'll get into that in a bit.
So another important decision is the timing of the reconstruction.
Meaning when we do the surgery?
Exactly.
Yeah.
So sometimes we can do an immediate repair.
Okay.
This is typically for clean cases like elective hernia repairs or some tumor resections.
So when there's no contamination.
Right. But in other cases, we might opt for a delayed repair.
When would we do that?
We would do that if the patient is unstable.
Like if they're in shock or something?
Yes. Or if they have other injuries that need to be addressed first.
I see.
We also delay the repair if there's active infection or if we need more time to optimize the wound bed.
So it's all about minimizing the risk of complications.
Exactly. We want to create the best possible environment for healing.
Okay, so that's the timing. What are the main goals of abdominal wall reconstruction?
Well, ultimately, we want to prevent evastration.
And what's that?
Eventration is when the abdominal contents protrude outside the abdominal wall.
Oh, wow. So that's what we're trying to avoid.
Exactly. We want to keep everything inside where it belongs.
Okay, what else?
We want to achieve a tension-free skin closure.
So the skin can heal properly?
Right? If there's too much tension, the wound is more likely to dehisce.
Okay.
We also want to restore the physiologic tension of the abdominal wall muscles,
Meaning what?
meaning we want to make sure the muscles are functioning properly.
Okay.
And finally, we want to provide dynamic support to the trunk.
So the patient can move and bend without any problems.
Exactly. We want to restore their quality of life.
All right, so now let's talk about the different materials we can use for reinforcement.
Okay.
You mentioned mesh earlier. What are the different types of mesh?
Well, broadly speaking, there are prosthetic meshes, which are synthetic, and bioprosthetic meshes, which are made from biologic materials.
Okay, so man-made versus natural.
Exactly.
All right, let's start with prosthetic mesh. What are the key things we need to know about that?
So with prosthetic meshes, we need to consider the pore size.
What's pore size?
Pore size refers to the size of the holes in the mesh.
Okay, and why does that matter?
It affects how well the tissues grow into the mesh.
I see.
We also need to think about the material's fiber composition.
Okay, so what it's made of.
Yes, different materials have different properties.
All right, so what are some common types of prosthetic mesh?
Well, there are absorbable meshes like those made of polygalactin or polyglycolic acid.
And what are those used for?
Those provide temporary support and are eventually broken down by the body.
So they're like a scaffold.
Exactly. Then there are non-absorbable meshes like polypropylene.
Okay, and what are the pros and cons of those?
Well, polypropylene is very durable, and it promotes good fibrous ingrowth.
So it's strong and it integrates well with the tissues.
Exactly. But it can sometimes be associated with problems like extrusion or stiffness.
Mean what?
Extrusion is when the mesh starts to poke through the skin,
Oh.
and stiffness can make it difficult for the patient to move comfortably.
Okay, so it's a trade-off.
Yes, every material has its pros and cons.
Then what about EPTFE?
EBTFE is another non-absorbable option. It's interesting because it doesn't promote tissue ingrowth,
So it just sits there.
pretty much, which can actually be an advantage in some cases.
How so?
Well, it makes it easier to remove the mesh if needed,
Okay.
and it may lead to fewer adhesions.
What are adhesions again?
Adhesions are those bands of scar tissue we talked about earlier,
Right.
but with EPTFE, you need to be careful about potential fluid collection around the mesh.
Okay, so that's something to watch out for.
Exactly.
So those are some of the common prosthetic meshes. What about composite meshes?
Composite meshes are basically a combination of different materials, or they might incorporate a barrier layer.
And what's the purpose of that?
The goal is to reduce complications.
Okay, so they're like a more sophisticated type of mesh.
You could say that there are many different types of composite meshes available.
And how do we use these meshes in surgery?
Well, when we're using a mesh as an underlay, meaning it's placed beneath the fascia,
Uh-huh.
it's generally recommended to put a layer of omentum between the mesh and the bowel.
What's omentum?
It's a fatty tissue that hangs down from the stomach,
Okay,
and it helps to protect the bowel from the mesh.
so it's like a cushion.
Exactly.
Mm-hmm.
And we always want to make sure the mesh is laid flat without any wrinkles,
Why is that important?
because wrinkles can create stress points that can lead to mesh failure.
Okay, so smooth and flat is the way to go.
Absolutely.
All right, so we've covered prosthetic mesh. What about bioprosthetic mesh?
Bioprosthetic meshes are becoming increasingly popular, especially in contaminated cases.
Okay, and why is that?
Well, they're thought to have a lower risk of infection compared to synthetic meshes.
That makes sense since they're made from natural materials.
Exactly. So these meshes are derived from cellular dermal matrices.
What does that mean?
It means they come from animal skin, usually porcine or bovine,
Okay.
and they go through a special process to remove all the cells.
So you're left